So, hello friends. So, today I'll be talking on this topic amniotic fluid embolism and pulmonary thromboembolism. So, this talk was given in one of the obstetric conferences. Quite an important topic. So, we'll just touch about amniotic fluid embolism first, followed by pulmonary thromboembolism. So, it was first recognized in 1926 by Mayer and was reported scientifically in 1941. And the occurrence of this amniotic fluid embolism, as we all understand, friends, is a very devastating complications with a very high mortality. Occurs in about 2 to 100,000 deliveries in database from US, Australasia, and UK. And it has put out as 1 out of 5 leading causes of direct maternal death. So as we know, amniotic fluid embolism in a severe form can really lead to instant deaths, and it can be very devastating. So it is shown to be one of the 5 leading causes of direct maternal death. So incidence from the few studies by Frati et al. Shows it is 5.5 per 100,000 or 1 lakh deliveries. And the case fatality rate in this Frati et al. Study from Italy showed it was 24.8%. And there's another study from Italy, Busardo et al., where they showed case fatality rate to be at 12.8%. With a range of 4.7 to 24.3%. So this is the sort of epidemiological occurrence of amniotic fluid embolism. So we need to understand what are the risk factors for amniotic fluid embolism. So the risk factors is elderly primary, age more than 35 years, or multiparous gravida, so who's had multiple pregnancies in the past, and any other pregnancy associated complication like preeclampsia, and any of these uterine complications like uterine rupture or abruptio placenta or placenta previa, and having a male baby, the male gender also constitutes one of the risk factor, or having any cervical tear, instrumentation during the delivery process, or cerclage removal. So all these are constitute important risk factors for amniotic fluid embolism. So the pathogenesis of amniotic fluid embolism. So usually you have this when there is abruptio placenta or placenta previa. So there's a lot of these fetal antigens or the toxins, which lead to production of multiple sort of like leukotrienes and cytokine release, like arachidonic acid, endotoxins, interleukin-1, leukotrienes, platelet activating factor, TNF alpha. So basically, there is a sort of a cytokine storm with release of a lot of cytokines and interleukins, which lead to sort of a extensive vasoconstriction and bronchospasm that sets in. And the fetal antigen present within the placenta can lead to extensive production of pro-inflammatory cytokines like interleukin-2, interferon, IL-17, and CD28. So all these lead to devastating complications. And the production of these tissue factor leads to activation of the coagulation pathway leading to DIC. And there is complement activation also in amniotic fluid embolism, leading to reduction in C3 and C4. The whole pathogenesis, if you see, where you have this fetal antigen and other toxins which lead to activation of cytokines or interleukins and all this, is very similar to septic shock or anaphylactic shock. So initially there can be vasoconstriction, but later on it leads to vasodilatation and shock and intense bronchospasm and coagulopathy. So these vascular compromise and respiratory compromise and coagulopathy and activation of coagulation cascade seems to be the hallmark of amniotic fluid embolism. So there was a study from this Italian group which showed that there is extensive mast cell degranulation also that happens in amniotic fluid embolism. So when we look at the clinical features, so amniotic fluid embolism, as you know, it's a devastating complication and they can have imminent death also. So seizures is something that is shown to occur, and they can initially appear very restless, delirious, agitation, and that may be the initial sign, followed by seizures. And hypotension may set in immediately after a transient rise in blood pressure due to vasoconstriction, subsequently followed by vasodilatation. And cardiovascularly, they can have arrhythmias, and imminently they can have cardiovascular collapse and cardiac arrest. And respiratory, as I said, the 3 important components in amniotic fluid embolism is cardiovascular, where there is a hypotension, then there is a respiratory component there where there is intense bronchospasm, and then they can, because of the leukotrienes and all the cytokine storm, then they can go into ARDS. And there is coagulopathy because of the activation of the coagulation cascade. So coagulopathy and MODS. So these are the 3 important domains of the symptomology that you can see. And when transesophageal echo is done, so they could have signs of right heart strain with pulmonary artery hypertension, and even left ventricular dysfunction can be present. And locally, because of the triggers that are present in the for amniotic fluid embolism, uterine atony, or one should look for any uterine tear or uterine dehiscence or in PPH, postpartum hemorrhage. So these are some of the local sort of complications that would have led to amniotic fluid embolism. So the Tsunemi et al. From Japan in 2012 classified this clinical presentation into three variants, which I typically said. So there is a classic variant, there is anaphylactic variant, and there is a DIC variant. So the classic variant is predominantly respiratory manifestations where they can have hypoxemia due to severe bronchoconstriction, and then which can later on lead to respiratory distress and ARDS. So the anaphylactic component would predominantly be seen as a cardiovascular compromise where they can have hypotension, arrhythmias, cardiac collapse and cardiac arrest. DIC typically leads to activation of the coagulation cascade leading to coagulopathy and DIC. So these are the three variants that they have described, but very often there is a always sort of a significant overlap between these three components, and not always it may be recognizable as one distinct variant. And it is shown someone who presents only with coagulopathy or coagulation cascade activation, the mortality is found to be less, and mortality is significantly high when there is a respiratory or cardiovascular component. So diagnosis is basically clinical, looking into the armamentarium of these three clinical spectrum that one would see in the patient. And UK Obstetric Society has come out with these diagnostic criteria, but for all the listeners, if you can remember this particular picture, so you have a cardiovascular component, you have a respiratory, and you have a coagulopathy, and there any overlap of these, one should keep in mind with the possibility of amniotic fluid embolism, especially when there has been a lot of uterine complications like uterine atony, or there is a uterine rupture, or instrumentation, or a large baby, or a male gender, or postpartum hemorrhage. Any of these, if it is associated with these systemic symptoms, one should keep in mind a remote possibility of amniotic fluid embolism. So laboratory tests, they have looked at certain antibodies. There is something called TKH2, which is monoclonal antibody against sialyl TN. And this particular sialyl TN antigen is found in meconium and amniotic fluid. And they have looked at the zinc corpoporphyrin 1 levels, which and these levels significantly go up. And zinc corpoporphyrin is present in placenta, and this has been found to be very high in high performance liquid chromatography, and complements levels like C3, C4 can be low. In the amniotic fluid, they have found increased levels of interleukin 6, interleukin 8, and TNF alpha, tumor necrosis factor alpha receptors, and there can be increased levels of interferon gamma, fetal beta protein 1. So these are some of the antibodies they have looked at in lab tests. And there are other adjunct lab tests that one should do to monitor the coagulation, monitor the complete blood counts, monitor the platelets, monitor the acid base and ECG, and so on and so forth. So, but these are certain specific tests that they have identified which tend to go up in amniotic fluid embolism. So the management is predominantly supportive, as I said, because there is a sudden cardiorespiratory compromise and patients can have cardiac arrest. So the algorithm of cardiac arrest in pregnancy have to be adopted. So the patient has to be put in tilt position, and the fetus has to be moved to remove the IVC compression. So there has to be these maneuvers that are done, and ACLS protocol has to be put in place. And whilst we are doing this, obviously one has to look at all the reversible causes, and emergency section has to be done even in the setting of cardiac arrest, because cardiac output would not improve unless emergency C-section is done in this situation. So the time is gold. So very immediate emergent measures have to be undertaken to save the life of the mother by delivering the fetus. At the same time, we have to look at 5H and 5T, which is hypovolemia, hypoxemia, acidemia, hypokalemia. All this typical cardiac arrest protocol has to be followed and put in place. And it is shown that the best survival in AFE, amniotic fluid embolism, happens in 24 to 25 weeks, post 24 to 25 weeks. And this cesarean section or perimortem cesarean section has to be done within 5 minutes, and that is the time frame they have looked at. So any further delay extending beyond this would really reduce the survival. So the time is the key essence. So immediate section has to be done to save the life of the mother. That remains the important quintessence of managing such complications. And one has to bear in mind that airway, there would be difficult airway in patients in pregnant because of the edema and the nature of the changes that happen in pregnancy. And the failed intubation has shown to increase morbidity and mortality. So it's always important, if unable to intubate, at least they have to be bag and mask oxygenation and ventilation has to be done with 100% oxygen effectively. And saturation really comes down very fast because the shunt fraction in pregnancy significantly increases from 2 to 5% to 12.8 to 15.3%, which means they do not have much of respiratory reserve, or FRC, functional residual capacity, will be lowered. So they would desaturate very fast. So it is imperative that all the expert airway management has to be done by an expert with all the difficult airway setup in place. So the management of amniotic fluid, whilst you have taken care of the cardiac arrest situation, if they haven't gone there, then hemodynamic optimization have to be done with adequate fluid resuscitation, with concurrent vasopressor initiation, and all invasive lines have to be secured. Arterial line has to be present to monitor the blood pressure more closely. And sometimes these patients may need additional mechanical support like intraarterial balloon pump or even ECMO or cardiopulmonary bypass to save the life of the mother. So these advanced measures may have to be kept in mind, especially when we are dealing with a devastating complications like amniotic fluid embolism. And when there is an extensive coagulation cascade that is gone off or a coagulopathy, then one has to bear in mind the transfusion protocol with 1:1:1 concept, where you have a packed cells along with plasma along with the platelets in this ratio. And the obstetric management is something that should not be ignored. So when there is a uterine atony, so obviously this uterine compression and mechanical devices to achieve hemostasis has to happen concurrently. So there has to be a medical therapy with all the obstetric medical management like oxytocin, along with surgical interventions, or in some cases endovascular interventions like angioembolization has to be initiated in situations where there is postpartum hemorrhage. And there is off-label use of recombinant human factor 7A as a desperate measure when things are not coming into control despite all these above measures. So uterine measures, medical measures, surgical interventions, and endovascular interventions have to be kept in mind when we are dealing with postpartum hemorrhage or uterine atony or uterine rupture or any of these complications, where obstetricians are the experts. So they should be working on these aspects, while the intensivists, anesthesiologists, and physicians are working on airway, breathing, and circulation and transfusion protocols. So one thing that has to be very clearly kept in mind is the survival of the fetus is very much dependent on the survival of the mother. So the whole priority in such a catastrophic, disastrous complications like AFE, the whole priority should be to save the mother, because only if the mother is saved, then the fetus can be saved. So the priority shifts to the mother because the fetal survival depends on survival of the mother. And it is very important there is an excellent or very regimental coordination between obstetric team, intensivists, anesthesiologists, emergency physicians, and neonatologists when we are dealing with this sort of a devastating complications. So that's about amniotic fluid embolism. So we'll quickly move to the pulmonary thromboembolism in pregnancy. So this is also looked at as one of the leading cause of maternal mortality at 1.08 per 100,000 maternities or deliveries. So risk factors are very similar to the AFE or amniotic fluid embolism. So obesity or body mass index more than 30, and someone who's had a history of stroke before, someone who is an active smoker, elderly primary more than 35, someone who's had a previous VTE are at a much higher risk of developing pulmonary thromboembolism or having any thrombophilic states or a prothrombotic states, someone with sepsis, someone with a cardiac condition, heart failure, cardiomyopathy, someone with a lung conditions like COPD or any other chronic lung conditions, or someone who has an inflammatory bowel disease or any underlying malignancy in pregnancy. All these become very important risk factors for pulmonary thromboembolism. Someone who's had abdominal surgeries or even someone who's having a catheters in the femorals, all these become risk for pulmonary thromboembolism. Someone who has hyperemesis, so they also sort of, because of the lot of volume loss, so these patients do carry a risk of having pulmonary thromboembolism, or someone who has ovarian hyperstimulation syndrome. So all these are some of the risk factors for pulmonary thromboembolism in pregnancy. Someone during pregnancy who takes a long flight of more than 4 hours is identified as one of risk factor for pulmonary thromboembolism. So those are the general risk factors. The obstetric risk factors are very similar to amniotic fluid embolism. So the same picture, if you remember this picture, age more than 35, multiparous gravida, preeclampsia, uterine rupture, abruptio, all the local complications, male fetus, instrumentation, cervical tear, circlage removal, uterine atony, rupture, or uterine tears. All these are the risk factors that are common to amniotic fluid embolism and even pulmonary thromboembolism. So in addition to this, in pulmonary thromboembolism, there's a concept called where virtuous triad, which plays a role, where these patients presence of small thrombus along with the coagulopathy and stasis of the blood, when compounded with the instrumentation, carries an increased risk of forming clots and thromboembolism. And it is shown that venous thromboembolism risk remains throughout the pregnancy from first trimester to the third trimester, albeit the risk is highest at around 20 weeks. So the half of the thromboembolism, venous thromboembolism, occurs at around 20 weeks pregnancy. And it is shown 75 to 80% of them develop DVT, out of which 10 to 12% of them constitute pelvic vein thrombosis. And pulmonary thromboembolism occurs in 20 to 25% of the patients. And pelvic vein thrombosis is predominantly iliofemoral thrombosis. So, and it is also shown even after delivery, the risk of thromboembolism is 20-fold up to 12 weeks postnatal. So it is not like after delivery, the risk is gone. So the risk remains for having clots up to 12 weeks postnatal. And first 3 weeks is the highest risk. So all this has to be kept in mind, that the risk does not fade away after delivery. The risk continues up to 20 weeks, highest being up to 3 weeks. And it is shown that left lower DVT is more common than the right DVT. It is 90%. There has been predilection of having clots in the left lower limb as opposed to the right lower limb. And iliofemoral thrombosis is found to be more common, 72%. So the diagnosis is obviously clinical. If you have someone with a swollen limb like this with erythema, one would immediately sort of a suspect. And whenever there is a suspicion, duplex ultrasound has to be done. If it is positive, the anticoagulation has to be initiated with enoxaparin 1 mg with low molecular weight heparins. Enoxaparin 1 mg per kg body weight has to be initiated. If duplex ultrasound is negative and there is reduced clinical suspicion, then there is no need for treatment. If duplex ultrasound is negative, but there is increased suspicion, then the directive is to repeat ultrasound at day 3 and day 7 to recognize and to pick up the thromboembolism. Otherwise, treatment has to be initiated with 1 mg per kg twice a day of enoxaparin. So there is something called left rule. So in pregnancy, when there is a suspicion, so one can look at the left rule, which is simply if the calf measurement on the left side is more than 2 centimeters than that of the right, then that could be the initial clinical suspicion that these patients are at a risk of venous thromboembolism, and further tests could be done. And this can be done in the first trimester, and this is called the left rule. So looking at the calf measurements on the left side, 2 centimeters more than the right side, so they can be followed up with tests to see if they are at a risk of developing thromboembolism. And D-dimer has no role in pregnancy because it will be high, and chest X-ray could be done to rule out any other secondary pathology. CTPA is a gold standard, but because of pregnancy, the risk is always there. So they have looked at breast cancer risk with the CTPA. It is shown to be 13.6% versus 1 in 200. So which means to say it does carry some risk exposing them to CTPA unnecessarily. And ECG, S1Q3T3, which is a typical presentation of PTE, occurs only in 40% of the patients. So management, as I said, low molecular weight heparin, this has to be continued for 3 months and definitely 6 weeks postnatal. As I said, the risk is very high up to 2 to 3 weeks post delivery. And someone who has developed pulmonary thromboembolism, there is a possibility of recurrent pulmonary thromboembolism in 1 to 15% that has been reported from this paper from UK investigators. So there is no role for newer oral anticoagulants, like if you're contemplating giving these newer anticoagulants, even in postnatal, it is not recommended. Dabigatran, rivaroxaban, apixaban, none of them are recommended in pregnancy and they need to be avoided. And if a pregnant lady develops heparin-induced thrombocytopenia, then fondaparinux can be considered as an alternative to low molecular weight heparin. So additional therapy, sequential calf compression can be considered. So this was a trial called SOX trial that came from the Canadian group, done in 800 patients. So here they compared whether the sequential calf compression was any better than the placebo. They found there was no benefit with the this is with graded compression stockings. So the socks that you put. So graded compression stockings had no benefit in post-thrombotic syndrome or preventing recurrent DVT. So sequential calf compressions along with graded compression stockings could be considered if there is contraindication to pharmacological therapy. So inferior vena cava filters can be considered. So the fatality of this, there are risks associated with this. 0.12 to 0.3% is the fatality. And these filters can migrate more than 25% of the times they tend to migrate. And there can be filter fracture in 5%. And IVC perforation can happen in 5%. So there are inherent risks that are associated when you are contemplating invasive procedures like inferior vena cava filters. And when there is acute massive pulmonary thromboembolism, so IV unfractionated heparin can be used. So risk of bleeding by using this is around 2 to 3%. So management, so suppose we are anticoagulating with low molecular weight heparin and these patients go on for delivery. So during delivery, the risk benefit of them developing venous thromboembolism versus them having bleed has to be kept in mind. And when LSCS or induction is considered, anticoagulation has to be stopped for 24 hours before these procedures are undertaken. When someone is at a very high risk for venous thromboembolism, IV unfractionated heparin could be used rather than low molecular weight heparin during the delivery process, or low molecular weight heparin could be reduced to prophylactic dose. And when there is suspected PTE, fibrinolytics has shown to improve survival. So in a as a salvage measure, when there is an acute cardiovascular decompensation, so percutaneous mechanical thromboembolectomy has to be considered when a situation arises during delivery, or embolectomy may have to be considered. So the take-home message at the end of talk of AFE and PTE is both are leading cause of maternal mortality. Amniotic fluid embolism pathogenesis, as I said, is very similar to septic shock and anaphylactic shock, where you have fetal antigens and toxins present in the maternal circulation that leads to the cytokine storm, that leads to respiratory complications like ARDS, on vascular complications like hypotension and cardiovascular collapse, and coagulation activation leading to DIC. These are the three variants. And the obstetric risk factors are very similar in amniotic fluid embolism and pulmonary thromboembolism, which is uterine atony, postpartum hemorrhage, placenta previa, abruptio placenta, uterine tears, instrumentation, male fetus. All these are very common for both. And diagnosis of amniotic fluid embolism is mainly clinical, looking at those three sort of a distinct presentation. And PTE, one could contemplate doing ultrasound or CTPA to identify pulmonary thromboembolism. Management of amniotic fluid embolism is predominantly supportive, good intensive care measures, taking care of airway, breathing, circulation. In gross hemodynamic compromise, patients may have to be put on ECMO or cardiopulmonary bypass. For pulmonary thromboembolism, treatment is anticoagulation with low molecular weight heparin. If the risk of bleeding is very high, one could think of unfractionated heparin. If there is contraindication to all these anticoagulations, then sequential calf compression with graded stockings could be used, although use of pharmacotherapy is far superior than these. And throughout this, we have to bear in mind the survival of fetus depends on the survival of mother. So the whole focus shifts to saving mother's life as opposed to the fetus when these complications arise. And can't emphasize more on very important and very meticulous regimental coordination between obstetrician, intensivist, anesthesiologist, emergency physicians, and neonatologists A good coordination between these two can lead to good outcomes and good survival of mothers. So thank you one and all.